think we've just hit critical mass, so we can get started. Once again, welcome everyone to our this month's Healthy Markets Community of Practice session that is going to focus on Malawi as a country. Next slide, please. So for those who might be joining us for the first time, the HMCoP is co-chaired, The HMCoP is co-chaired by USAID and UNFPA, represented by Andrea Baer and Ben Light, and is an evolution from the Total Market Approach Technical Working Group, which has been operational since 2014. The HMCoP seeks to generate awareness of FP market development and private sector engagement work happening in countries, and for participants to sort of discuss, engage, and live with a greater understanding and appreciation of the country's health market, and particularly the role of the private sector within those markets. I would just like to remind everyone. So firstly, thank you for joining on our new Zoom platform. We've been trying out some different platforms to see what would be the best way to create an engaging environment. So thank you for bearing with us. As far as that is concerned, I would just like to remind everyone to, please feel free to put their names and, their titles, etc. information in the chat. Let's make the chat lively. This session is recorded, and a recording will be shared along with a summary after the session. And yeah, before we move on any further, I would like to invite Andrea to provide us with some opening remarks.
Awesome. Thanks, Farhan. And welcome, everyone. Andrea Baer with USAID Washington. And I really won't say a whole lot beyond what Farhan said, but just one thing to say, thank you for the support and dedication to this this community of practice. And as Farhan noted, for your patience with some evolution in technology and so on. And you'll see that the FHM Engage team is continuing to evolve this approach. And we very much invite ideas and speakers going forward. So looking forward to a lot of great talks, and also with a shout out to our USAID Malawi colleagues, Bertha and Jen, and I think others who may be on the line who will share some comments later. I think Bertha will. So with that, back to you, Farhan, and thank you.
Thank you so much, Andrea. Next slide, please. Well, yes, to provide a bit more insights. So firstly, my name is Farhan Yusuf, and I am the moderator for these sessions, and I work with FHM Engage. And ideally, the HMCoP aims to be locally focused with increased participation by in-country partners and actors. Our goal is for these meetings to be dynamic and interactive, and to facilitate more connections around market development and private sector engagement. We want to share the work that all the different amazing partners are doing in specific countries to increase the utilization of health services from the private sector, and particularly family planning. For this particular session, we would definitely want to give out a shout out and appreciate PROPEL Health, fellow project that has been on the ground in Malawi and helped us with organizing these amazing speakers that we have lined up for you today. So without taking much of your time, I would love to move on to our first presentation. Well, before that, our agenda. These are the presentations that we have lined up for you today. We will then have the concluding remarks, as Andrea mentioned, by Bertha Migodi from USAID Malawi, and then hopefully have a lot of time for some discussions at the end. A quick reminder to my speakers before we move there, let's please abide by the 5 to 6 minutes time that we have given, so that we have enough time at the end. I will be sort of interrupting when we are close to ending time, just to make sure we can keep up with the pace. Thank you so much. Moving on to our first presentation for the day, I would like to invite John from PROPEL Health to take us through our first presentation that will sort of provide a landscape overview of private sector FPSRH in Malawi. Welcome, John.
Thank you very much, Farhan. Good afternoon and good morning, everyone. So in this presentation, through a brief overview of the family planning uptake in Malawi and the gaps which exist so far, and also I'll briefly talk about the opportunities which are there for the private sector engagement, and also what the ministry is doing so far to create an enabling environment for private sector engagement, and I'll end on talking about the PROPEL Health's role in supporting the government in its initiatives for creating enabling environment, as well as creating governance structures for private sector. Next slide, please. So to begin with, as a country, Malawi has made significant strides in increasing the modern contraceptive use. As we are talking now, the modern contraceptive preference rate is at 49%, indicating that almost half of all women in Malawi have good access to modern contraception. And this is according to the recent Track 20 modeling, which we have done in country. However, this preference rate for family planning only represents 79% of the total demand that we have for modern contraception, which means we still have a gap because unmet need for modern contraceptives remain high, as we are talking 13% of all women still have unmet need for family planning, while 14% for married women. And the situation is even worse when it comes to adolescent girls, where their unmet need for modern contraceptives stands at 72%. So we can see that while we have made significant strides, but we still have some way to do for us to cover the whole demand that we have. Next slide. So when it comes to the method mix in the modern contraceptives, you will note that in Malawi, the modern contraceptive preference rate is largely driven by injectables. So currently, injectables contribute to 52% to the MCPR, while long-acting contraceptives and treatment methods is at 41.5%, and much of it is implants. So this implies that most women in Malawi rely on short-acting methods, and we still have a lot of work to, I think, creating demand for long-acting methods if we are to push our MCPR up further. Next slide. So this slide I want to talk about how the family planning market in Malawi is segmented. So in Malawi, the primary source of the contraceptive methods is the public sector, with 79% of all users accessing this the products from the public sector, and only 20%, which is one in every 5 women, relying on the private sector for their modern contraceptives. Another thing that you have to note is that among the users which are getting contraceptives from the private sector, most of them, about 63% of them, rely on socially marketed and subsidized contraception. So in this case, we are dividing our private sector market into two, like the commercial market as well as the socially marketed methods. Next slide. So for the total market now, when we're analyzing the total market and which market is providing which method, you note that the NGO sector, which in this case we are calling them the socially marketed commodities, are the major providers for oral contraceptives. And they have also, when you are looking at the trend from 2016 to 2021, their provision has increased significantly, up to 106%. While when it comes to the commercial importers, their major commodity that they import much in the country is the emergency contraceptives, AC. In 2021, the total market of ECs was about 102,000 units, and it increased by 601% in 2016. While when it comes to the public sector, the major commodity that they provide is the injectables. So you would see that even their trend has increased significantly in that period that we are looking at by 79%. So that's how the market is segmented, with social market providers providing more of oral contraceptives, and the commercial sector is more of providing the emergency contraceptives. Next slide. So, having looked at this background in terms of the strides that we have made so far and the gaps that I have just highlighted, I would like now to share what can private sector do in order to help the government of Malawi to fill these gaps. What are the opportunities which are there in Malawi for the private sector? So the first opportunity, as I indicated, is to close the gap with unmet need. As I said, unmet need stands at 13% among all women, and we need, this is mostly attributed to perennial stockouts, which we experience as a country over the years. And whenever there's a stockout, women always flock to private providers, including the private pharmacies. So this is where the private sector can come in now to fill in the gap. So when the public sector, which is the primary provider for family planning, is out of stock of some commodities, then women will learn to them, and that's the market on its own. Apart from that, the data also indicate that women in Malawi have the capacity to pay. Data shows that 70% of the wealthiest users of the family planning methods are accessing the public sector, which means they are accessing the funds from the private sector, public sector, but they have the capacity to pay if the market is there. So that's another opportunity that the private sector can utilize to fill in the gap of the stockouts while utilizing the capacity of the users to pay for the commodities. Another opportunity which is there is the demand for new products, because currently there are varying dynamics among different users. You talk of young users and talk of old users, and these have different preferences in terms of which type of commodities should they use, and of which maybe the public sector as the primary source cannot satisfy all the varieties of products that they have. So if the private sector can bring in different commodities of different tastes, this can also bring in market which can satisfy the varying preferences of the family planning users. Then we recognize the fact that the private sector has got the market capacity, because they have the financial muscle to procure the product into the country. They have the capacity to reach the last mile of the users. So in terms of supply chain, they have very good capacity which they can utilize to fill in all the gaps that we are talking about. And on top of social cultural factors which sometimes hinder or promote the unmet need for family planning, you see that people sometimes are failing to access the services from the public sector because of the attitudes of the service providers, and also sometimes because of less confidentiality which is there in those public service providers, and they learn to the pharmacies or private service providers because there is non-judgmental attitude among the providers, and also there is the level of confidentiality in the pharmacies and the private clinics are very high. So the private sector now can utilize this opportunity to provide a wide range of commodities or methods, not only emergency contraceptives, taking into account these factors as promoting their demand. Next slide.
Yeah, John, if we can quickly summarize, please.
Yeah, okay. No. So having recognized the critical role that the private sector can do, not only in family planning, but also in the whole health sector, across all the building blocks of the health sector, the ministry now envisions a public-driven and innovative sustainable health system towards the attainment of the universal health coverage. As such, it has established public sector engagement forums for increased public sector participation, innovation, and investment. Next slide. So as a project, PROPEL Health now is supporting the Ministry of Health in its endeavor to create an enabling environment for private sector engagement. So what we have done so far as a project, we have supported the ministry to develop a private sector engagement framework, which is illustrating how committed the government is in private sector engagement. We have also helped them to establish a sub-10 working group, which is looking at the private sector engagement things. And we also identified a local CSO, like social organization, which is there to mobilize the private sector. And as a project, we are capacitating this organization to effectively do their role. And currently, we are supporting the ministry to also develop a business case compendium, which can aid the private sector to analyze the business investments opportunities which are there in the sector, so that they can have a informed decision on which one to take on. And we are also rolling out the private sector engagement framework at the district level, so that private sector not only at the national level, but at all levels, including at the primary healthcare levels. So this is the end of my presentation. Thank you very much.
Thank you so much for that, John. So I have received a message from Dr. Dumisani that he might be delayed. So maybe we'll move on to the next presentation from PSI Malawi. And as we do that, thank you so much, John, for providing this overview. And I see there's already interesting questions in the chat for you. Can we have Martha, please, from PSI?
Thank you so much, Farhan. My name is Martha Valeta, PSI. So I'll be taking you through what PSI has been doing in the private sector in regards to social marketing. Next slide. Yeah, so as PSI, we are a network of locally led and globally connected organizations that are passionate about making it easier for people to lead healthier lives. Let's go to the next slide. So our journey in Malawi. So PSI has been here in Malawi for over 30 years, since 1994. Recently, in 2022, there was a financial deconsolidation that led to a birth of Family Health Services, which is still a network member for PSI Global. Our focus is provision of technical assistance in the realm of SRHR, HIV, malaria, and also maternal health. We are also supporting Ministry of Health in health systems support. We are also working with the local NGOs in quality programming and compliance. Let's go to the next slide. Yeah, so whatever I'll be talking here is actually the work of PSI and the FHS, which is a local organization, because we won until 2022. PSI, as I've already said, has been implementing social marketing since 2007, with introduction of the Safe Plan brand, as you can see in the slide being presented. The work involved more of the combined oral contraceptives and also the 3-month injectable contraceptives. For the male and female condoms, they were already on the market, but PSI did more of its work on the two products I've talked about. So introduction of contraceptives in the private sector through private clinics and also drugstores and pharmacies. So that's what PSI had laid grounds on at the beginning. The activities that PSI supported with included training of providers, detailing, and also commodity distribution at a very subsidized rate, just to make sure that the facilities I've mentioned above, clinics, drugstores, and pharmacies, can access and also trickle down to the consumers at an affordable rate. For the PSI also introduced emergency contraceptives in 2014 as part of its social marketing. Next slide. Okay, so right. So I was just talking of the social marketing. Then I'll talk of the franchise piece that PSI has worked on. So PSI established its social franchise in 2013, starting with 30 clinics. So this was support given to private clinics just to make sure they get the products at a subsidized rate, but also beyond just the products. PSI worked on provision of quality support. That's the actual provision of services. It started with fewer clinics, 30 clinics at the beginning, and over time we saw an increase in the numbers of the clinics. We went up to 70 clinics, but then the numbers were fluctuating, mainly because of the quality. So PSI did not just focus on the commodity provision in the private clinics, it also worked with the quality, how the services are being provided. So we're also giving support on quality provision of services. And we also ventured into long-acting reversible contraceptives. That is, we're looking at the whole range, broader range of contraceptives, giving support to the private clinics. More support also added on into demand. So PSI was actually supporting the catchment within the private clinics with training of mobilizers. So these community mobilizers were creating demand for the services at the private clinics. We've also seen quality assessments. So besides training the providers in the private clinics, PSI supported with conducting quality assurance assessments routinely to these private clinics, and also providing business management trainings in these private clinics. Let's go to the lessons that we've learned so far. Next slide. Yeah, so much work has been done, but there's still a lot that we've learned and also that should be considered going forward. The first one, we've noted that it's important that we clearly define the role of private sector so that we see which segments of the population need what which services. So we've noted that various segments of the population require various private clinic services. And in Malawi, you can agree with me, there's urban clinics, peri-urban clinics, and also those that are in the rural areas. So we've noted that over time, most of our population are still accessing services from these private clinics. Initially, we thought it's only the people that are wealthy that can access these clinics, but I think over time we've learned no, even the other segments of the population that we had not thought of accessing services in the private clinics or drugstores or pharmacies. Hence, the need for us to invest in these private clinics. We've also seen that we need to consider growing instead of shrinking the private sector. What do I mean here? So as we program, or as ministry, as we work towards our programming for the marketing piece, we have to consider that these private clinics, drugstores are actually complementing what the government is doing. So all efforts that are being done at national level, they have to support efforts that these private clinics are doing. For example, if we make all commodities free, then what are we talking of the private clinics? Because these guys are there to make a little bit of a profit. So we also have to consider in our programming that these private clinics are trying to support a segment of the population that we cannot reach as government or as private sectors or as NGOs. And also we have to ensure that interventions include monitoring and accountability mechanisms. Let's not assume that the services that the private clinics are providing are of good quality. I think most of you can agree with me that in these private clinics, they are mostly behind on trainings, on protocols, updates of standards, everything. So as we move forward the SRHR piece and the FP service provision, let's consider these private clinics and let's just always focus on them as we move forward. So I'm talking of Ministry of Health taking full responsibility, monitoring the activities going onwards. Another thing, we also have to work closely with the regulators so that no one is left behind. It also agrees with the point on top, whereby we want to take the medicines, poisons board, nursing and midwifery councils, medical council. We take them from the beginning. As private sector, we don't have to go to the private clinics alone, but we have to go with the regulators. In case our funding phases out, we leave these regulatories to go on with the private clinics because these clinics will be there for good. So let's make sure that we are working with the regulatory bodies and not just working silos. So that's what we've learned so far. We also have to consider self-care perspective. You can agree with me that deep in the rural areas, these private clinics in most of our communities are not there. So let's consider the community mobilizers, CBDs that the government has. Let's consider a piece that it can be of sort of social marketing. Let's give them the products at a very subsidized rate, then they go on, they provide the services in the communities. Because we've noticed these ones are also doing a lot for the FP provision. So I think we've learned that, and we feel like that can be a plus as a country. Yeah, I think the last one is the very last slide. Just yeah, so this presentation has been made possible, yeah, with support from UST and also from German Cooperation through KfW. Thank you so very much.
Thank you so much, Martha, and so many key points in your presentation that I think are very relevant, especially the focus on business management and ensuring that the private sector can make some amount of money, and also the perceptions around how people can afford and not afford. But moving on, we can discuss more later. Moving on to our next presentation from Mothers to Mothers, we have Tendai Mayani. Tendai. Tendai, are you on the call? Okay, maybe we are missing Tendai for now.
Good afternoon. This is Tendai.
Yes, Tendai, welcome.
Sorry, yeah.
Welcome.
Yeah, so this is Tendai Mankaunda, the Programs Director for Mothers to Mothers. I'm going to present the family planning services that Mothers to Mothers provide in the catchment areas that we reach out to. And the slide is composed of overview of Mothers to Mothers, then Mothers to Mothers Malawi, family planning services in Malawi, as of Mothers to Mothers provision, previous success dates, and future focus. Yeah, so mothers, yeah, let's move on. Mothers to Mothers have been, it started in 2001, that is in South Africa. Can you move back? Yes. And we usually use a peer mentor model whereby we have got mentor mothers that create demand. Okay, can you move back? I think you have gone to another slide. Yes. Yeah, so the mentor mothers are the one who provides life-saving health support to hard-to-reach communities across sub-Africa. And the mothers peer mentors are regularly trained, paid, and employed community health workers. They are not volunteers, but they are paid by mothers to mothers. So they engage and support women and families in their communities to prevent, identify, and address a range of primary health issues, from malaria to all the health issues that you may think of. They also provide services and support, including counseling, health education, and screening in person and through digital health platform. We have got a digital health platform, which we call it Virtual Mentor Mother Platform, whereby all the, it's a WhatsApp platform whereby all the health diseases, most of them, they are there, especially concerning sexual reproductive health. And anyone can access it if she has the number or he has the number. And also the mentor mothers, these are the peer mentors, provide referrals and linkages to the health system for services and treatment. And also they address holistic health needs of women and families, including and beyond HIV, such as sexual and reproductive health, nutrition, and childhood development, and infectious diseases like malaria and tuberculosis. The peer mentors, that is the mentor mothers, have been changing lives in South Africa, Lesotho, Zambia, Malawi, Mozambique, Angola, Uganda, Kenya, Tanzania, and Ghana. And also they earn income to support the economic well-being of themselves and their families. You can move on. Another slide. Yes, so over the last 20 years, Mothers Peer Mentor model has achieved significant impact. We have helped over 2 million at-risk women and children alive, and also operational in 10 African countries, that is currently. We have created jobs for over 12,000 African women living with HIV, as I've already said, that the mentor mothers, they are employed, and all of them, they are HIV positive. They reached out over to 15 million women, children, and families with life-saving health education services and support. And over the years, we have achieved a virtual elimination of mothers to child transmission of HIV among enrolled clients for 9 years in a row. That is helping a new generation start life HIV-free. And also we have helped keep over the past 7 years alone. Let's move on. Another slide. Yeah, so in Malawi, Mothers to Mothers started in 2008, and previously we were known as a PMTCT. People knew us as a prevention to mother to child transmission organization, but now we have widened our scope, Our country director is Dr. Bridget Malewezi, and currently we have got 12 office staff, 78 site staff. That is mentor mothers, adolescent teen mentors, and nutritional facilitators. And we are in the location, we are in 5 sites, but it's 7 sites, not 5 sites. And we have got diverse funding from private foundations, corporate, and material donors. We are working closely with Ministry of Gender, Community Development and Social Welfare, and Ministry of Health. We are also working closely with the expanded program immunization department and also Department of Nutrition. And mostly we are doing direct service delivery. That is the direct service delivery. We are integrating HIV, reproductive, maternal, neonatal, child, adolescent health, nutrition, and early childhood development. We are also demanding creation for immunization and family planning services, adolescent health and youth programming, and also we are doing cervical cancer screening and breast cancer screening in 4 sites, and also we are strengthening community health systems. The facilities that we are in Kabudula, Mitundu, Lumbadzi, Bukwe, Kawale, Chitedze, Bwaila. Those are the facilities that we are in. I hope I have mentioned 7 of them all. Let's move on. So on family planning services, mothers to mothers, our payment model, we don't provide services, we just create demand. We create demand, and if somebody wants a family service, a family planning service, we link that client to the service providers. And later on, we also follow up the clients if they are due for an appointment. For example, if the client accessed maybe oral contraceptives and she's due maybe after 3 months, or how many, she's supposed to have another appointment and has missed an appointment, our mentor mothers, they follow that client to ensure that she's back to care, unless if she wants to have a child. So we conduct all these activities like the creation of demand in healthy facilities as well as in communities, in youth-friendly healthy services, as well as using the e-services. Our mentor mothers assures that the clients are aware of the contraceptive mix of choice and aware of the side effects of which, as already discussed, between the clinical service provider and the client. Mentor mothers are positioned in the client flow where postpartum mothers are found, that is in the facilities. Immunization clinic, this is to create demand and link clients for family planning services. We also conduct health talks, that is the mentor mothers at outpatient department, postnatal ward, and the 5 clinics to create demand on family planning. The mentor mothers, they also, after creating the demand and those that they want the services, they link the clients to health care providers, and the health care workers, they link the clients to the service providers and follow up all the clients that have missed an appointment to ensure they are retained in care. In the communities, these mentor mothers are just employed for the community work. So each and every day they go into the households just to create demand, and all those that want family planning services, they are linked to service providers. We also have the parenting sessions whereby they also provide the messages, they disseminate information on family planning. At the youth-friendly health services, as we already said, that we have got adolescent mentor mothers. These peer mentor mothers, we have got the 2 categories, adolescent as well as adult. So for the youth-friendly health services, the adolescent mentor mothers, they are the ones who disseminate information in the youth-friendly health services, but they also do it in the households as well as in the youth groups. They also provide condoms in the youth-friendly health services. For the e-services, as I've already talked about, the virtual mentor mother platform, this is a chatbot-based platform that includes information on family planning and a help desk that can be accessed anytime, expanding access to information. Another slide.
Tanda, if we can summarize, please.
Okay. Thank you so much. So on the client reach, we have reached out to 10,159, that is in 2023. And among us, the 10,159,159, which we reached 69.5% we were able to reach out with modern methods, and that's the figure. And the 70.1% were injectables, 0.3 IUDs, 0.03 tubal ligation, and 7% condoms. For the adolescents, that is also the figures that we were able to reach out to. 82% were injectables, 0.2 IUDs, 15.6 implants, 3.1 oral contraceptives. Move on. Yeah. Future focus, we want to integrate comprehensive sexual and reproductive health service package. We want to strengthen linkages between the health facility and communities. We want to further develop the adolescent programming to serve the needs of the AGYPI, adolescent girls, young women, as well as the adolescent boys, young women. Thank you.
Thank you so much, Tendai, and I think very relevant because behavior change and SBCC, it's very important, especially when you're talking about groups like youth, etc. But sometimes it may not get as much focus as some of the other aspects. So great to see the work that you and your organization are doing. Moving on, can we have Olive Mtema from Momentum Tiyeni? Welcome, Olive.
Thank you, Farhan. So good afternoon, good morning. I'm Olive Mtema. I'm the Chief of Party for Momentum Tiyeni Project. Momentum Tiyeni Project is a consortium of about 6 companies. We, Palladium, we are the prime with our partners on the project, Save the Children, Pakajere Evangelical Association of Malawi, Family Planning Association of Malawi, and PACHI. So it's a 5-year project. We launched it in 2022 up to 2027, and we are operating in 7 districts of the country, 2 in the central and 5 in the south. And our primary goal is to support the Ministry of Health, their main goal from reducing maternal and newborn mortality. Their target as the ministry is to reduce maternal mortality from 349 per 100,000 to 258, and also for the newborn mortality from 56 per 1,000 to 35 per 1,000. So as a technical support project, we are contributing to that goal. Our main objective to achieve that is to support improving access to and demand for use of evidence-based quality, maternal, newborn child, and also family planning and reproductive health, nutrition and malaria in pregnancy services, and also interventions that are scaled up in these 7 districts that we're working in. And we're not only working with the public sector, we're also looking at supporting private sector facilities in these districts. So our main approach is mainly technical assistance to the government, Ministry of Health mainly, at national level and district level, plus also community level, mainly to provide, maybe plan together and provide the financial assistance to implement the activities, but also accompaniment, our technical advisors working hand in hand with their MOH counterparts in planning, and also in doing that, we're transferring skills so that this is sustainable beyond the project. And in addition to the Ministry of Health, also working with other partners in strategic planning and also collaboration. But on the project for this presentation, I'll focus on the support that we are providing the government in partnership with Family Planning Association of Malawi, which is a private entity on our consortium. Next slide. So John provided already the snapshot of the trends in Malawi, but for a project like ours, we are contributing to increasing access, but also meeting the demand. As you can see that the demand is still high at 13%, and also we have a high and certified demand from for contraception. Next slide. So our goal as Momentum is to support increased family planning service availability and quality and use. So we do that by supporting the ministry in capacity strengthening of service providers, but also the demand creation and also support through private sector partnerships. Can you click again on that slide? Yeah. So for increasing demand, we are working at looking at mobilizing the communities on the ground through targeted SBC interventions at community level. We trained drama groups, but also through our partner on the project, Evangelical Association of Malawi, we trained religious leaders. So we mobilize the communities through a number of demand creation activities, also including community radios and also mass media. So our game changer activity for increasing access is really taking the service to the remotest area. As you all know, Malawi is a rural country. More than 80% are in the rural area, and the facilities are far apart from the communities. So women are still walking long distances to facilities. So our game changer activities to provide integrated family health outreach clinics, which family planning is part of the package, but we provide an array of services. And we also establish under this project, supporting government to come up with establish youth-specific outreach clinics. So demand generation is provided prior to the outreach in the catchment area, with the religious leaders who talk about family planning and the services that are going to come maybe in the next 2 weeks. And we saturate the community with the demand so that when you pitch the outreach clinic, we have patronage. For the private sector partnership with FIPAM, so what the project is doing, we supporting government to increase the frequency of outreach clinics, because most of the times government doesn't have resources like transport to get to the outreach clinic. And with FIPAM, we also establish like a standalone team that goes out also to the underserved areas in the catchment to complement government efforts. So we work with FIPAM and also the Christian Health Association of Malawi. You may all know that most of the CHAM facilities are managed by Catholic Church. So the Catholic Church do not provide modern methods of family planning. So in partnership with FIPAM, we also make sure that the outreach clinics in the rural areas, we go also to support around the catchment areas for the Catholic churches where people do not have access to modern methods of family planning. So working together with FIPAM, CHAM, planning together and learning from each other to support government achieve access to family planning. Next slide.
Yes, Olive, if we can summarize, please.
Yeah, so you can see that as a project, we're leveraging existing private sector companies like family planning and the CHAM, because they are non-government, to increase access to family planning. But also going forward, we are looking at how can we engage the private companies like the tea plantation, the sugar plantation, so that they are able to also invest in providing family planning services within their companies, but also the communities around them, maybe working with them to also increase access through the outreach clinics. Next slide. So you can see that as momentum, this is our year 3. Year 1, you can look at the numbers. As I said, family planning, family health outreach clinics, a game changer. You can see the numbers that we achieved in year 1 and in year 2. So more than doubled. And then the establishment of youth-specific outreach clinics also helped us to reach out to the young people, because young people could not maybe patronize the services that are also meant for adults. And our main challenge in working with private sector has been maybe it takes too long to really bring government and private sector together, but also for capacity building for the private sector companies, it is difficult because they cannot allow their service providers to maybe take time for training. So we are also exploring some smart capacity building, working with these private sector companies. So this is what I can share for now. Thank you.
Thank you so much, Olive. And what a good note to end on, because I think this idea of being able to train the private sector in a way that is friendly for their business models, I think is something very important for us all to brainstorm together and think about. The next presentation is by Charles Bhango from Banja La Mtsogolo. I hope I'm saying that right. Welcome, Charles.
Thank you, Fan. Good afternoon, good morning, good evening to everyone. So I'll take you through BLM's stand. Next slide, please. Okay, so a brief introduction about BLM. We are a senior partner of MSI Reproductive Choices, which is a global partnership of 35 countries. We are established in 1987, so we have moved together with the ministry since 1987. Our role mainly has been to support Ministry of Health, Family Planning, SRH, as well as General Health Services. Currently, our presence is in 26 of the 29 districts. We go by the vision, children by choice, not chance. And what we are looking forward is to see a world where every birth is wanted. Just a snapshot of our performance results in 2023. We actually managed to save 676,000 clients across Malawi, of which 563 of these received the family planning or post-abortal care services. We actually accumulated 866,000 SWIPs from the FP services we provided in 2023. 14% of our services were obtained by adolescents, those people less than 20 years of age. We can see that we averted maternal death by 1,000. So 1,000 maternal deaths were averted by our performance, and also 115,000 unsafe abortions were averted through the services we provided, and 425,000 unintended pregnancies were averted. Next slide, please. So we deliver our reach through several channels. Our first channel is through static centers. So we have 25 static centers. These centers basically are providing family planning services, SRH, including post-abortal care, as well as the general medical outpatient services. And we also have 17 mobile outreach teams funded by different donors. Mainly, they are actually providing family planning and cervical cancer screening. A few others also providing STI management and HIV screening. We are also working with the ministry through one of our channels we call public sector support. Under the public sector support, we are supporting 81 public facilities with a key focus on family planning and post-abortal care. So mostly this is a healthy systems strengthening program, also with a special focus on mentorship and capacity building of providers. The whole essence of bringing up this program was actually to ensure sustainability, because we know with the dwindling resources, we have significantly reduced our outreach teams from around 29 in 2022 to 17 currently. So we think if we can still capacitate the government staff who will always be there, because it's still government's responsibility to provide the services, and be able to provide quality FP and PAC services, then we are good even if BLM is no longer there with the further support. We are also operating a social marketing channel where we have a network of more than 2,000 outlets, mostly private pharmacies, drugstores, and private clinics. We have our social marketing products. We have 2 male condoms, branded Manuch Premium, and Manyuch Classic. We are also providing emergency contraception. So our social marketing EC is blended backup, and we also provide misoprostol, blended misoclear. We also have pregnancy test kits. We are in the process of introducing combined oral contraceptives on the market. Recently, we have also introduced a variety of antibiotics. Our last but not least channel, it's a contact center. So we have a contact center with 3 call center agents. It's a free toll line, 1131. Basically, its role is to provide SRH information, referrals, but we also use it to follow up our clients who have received high-risk services within our facilities or outreach teams. Next slide. Okay, so going specifically to interventions related to the private sector, we actually supported the Ministry of Health through RHD to develop DMPACC guidelines for private pharmacies through funding we got from CIF, administered by CHAI, the Catalytic Opportunity Fund. After developing the guidelines, we also supported with the rollout of the guidelines through training of providers from the private pharmacies, because they are actually using commodity from the government. We also facilitated the signing of MOUs between the government, the district councils, and the specific private pharmacies. We have also been supporting commodity distribution to these pharmacies, as well as supporting MOH with the supportive supervisions. We also supported the development and printing of FP tools for the private pharmacies. This is first of its kind, because we know pharmacies, drugstores have been providing ECs, other CCOCs, but actually tracking now the performance or actually the numbers in these private pharmacies has been a challenge. So with the development of these tools, the government hopes to actually achieve, to actually be able to collect data and see the actual impact the private sector has. So the tools have not only focused on DMPACC, but all other FP methods, including EC, COCs, that are actually provided in private facilities. So we are also selling our social marketing products at an affordable wholesale price, making it easier for private pharmacies. Since these are businesses, they also have to make profit out of it. So we provide an affordable wholesale price. We have created for the outlets we are working with under social marketing, we have created a referral pathway to our facilities, so that if there are any other clients that they need to refer to, they can also refer to us, whether for a service that they are not providing, or maybe also for possible adverse events that they might have experienced, they are reported to them. So we have created a referral pathway so that they're able to reach us. Next slide, please. So looking at the successes.
Charles, please. Thank you.
Oh, okay, fine. Looking at the successes, as I already mentioned, we supported the operationalizing of the guidelines. We are actually happy that some private pharmacies now are actually effectively reporting on the numbers, and we have also managed to develop a wider reach for our clients with the FP-SRH commodities. In terms of challenges, one of the key challenges has been frequent staff changes within the private pharmacies. So today you train providers within the pharmacy, you come next time, that person has left. It means there is no longer someone trained. You need to consider also the training someone. but also stockouts has been an issue where there are stockouts. Obviously, government facilities have become a priority rather than the private facilities. In terms of next steps, we plan to support rollout to more pharmacies. We currently have a seed funding that is supporting the rollout. Thank you.
Sorry, I did the thing that we always do where we speak and forget to unmute. But yeah, thank you so much for that, Charles. Again, very interesting, and I love seeing the challenges because there's always some recurrence there. And I think there's a lot of expertise in the room where we can learn from each other and figure out how to, solve some of these challenges, such as staff attrition at the pharmacies, etc., which is something that we see so much in many different settings. Now, we were supposed to have 3 other presentations, and I would like to check if those presenters are here. Is there any representative from the Christian Health Association of Malawi? Okay, I see not. Any representative from Family Planning Association of Malawi? We were supposed to have Dr. Donald, but I don't see him, and I'm not sure if there's any other representative. The good thing is that in the momentum presentation, we have already seen some of the things that both of these associations are doing in close collaboration with the momentum project. So I think it gives us some idea of the work that they are already doing in country. And lastly, we had one commercial provider from Malawi, from Horizon Health. I can't see LC here, but is there anyone else as a representative? Okay, looks like we don't. I mean, at any point of time, if they join, I'll keep an eye out and see if they get an opportunity to sort of contribute to our discussions. But at this point, then, I would like to invite Bertha from the USAID mission in Malawi to provide us with her remarks. Bertha, are you there?
Yes, I was trying to unmute myself. So good morning, good afternoon, everyone. My sincere apologies. The time I was trying to join, I had internet challenges, so I joined a bit late. I think I joined and then, but it kicked me out of the meeting. So for me to rejoin, it took me a while. So I joined when PROPEL's presentation was almost at the end, but I would like to acknowledge the efforts of each and every stakeholder here who availed themselves to make their presentations and share, really to connect and see what is already being offered on the ground in Malawi. So it's very interesting to know that there are lots of players in Malawi really supporting private sector efforts to expand FP services. So this is very encouraging to know we have those efforts beginning from the policy support. We saw what PROPEL Health is doing, supporting the government of building the private sector framework, and we're seeing those opportunities that are already there, in which our private sector efforts could fill in the gaps. We already saw that there are already 70% of wealthier women that could, if we expanded our private sector clinics, then those wealthier women could be sourcing out their FP services from those private sector clinics, but yet we see that they are getting these services free from the public. So I think if we do good collaboration, we will do a good work really to ensure that those wealthier women should be able to really access the services from the private sector. That way we are expanding our market base. We're expanding other outlets for and options for women who want to do so. So I would also like to acknowledge all the efforts being done in terms of demand generation by mother to mother, the social marketing components being done by PSI, but also engaging doing business management models. So I also want to acknowledge what momentum Tiyeni really is doing in terms of already working with the FIPAM in expanding their services to hard to reach areas, but also the initiative that they start to engage the private, other companies that they also expand services in the areas within their catchment areas. So I think as we want to reflect on this, what I would really want to encourage that we do continue to have this kind of platform, this kind of coordination where we share what we are doing. We share what is it that is working well. We share what are the challenges and also try to explore what would be the possible solutions so that we expand the private sector engagement in the FP space. So lastly, I really want to thank those that organized this community of practice and specifically for engaging us at the mission so we know what is already being done. And that really ignites our thinking really to say how more broadly can we really put efforts to expand the private sector thinking within our country. So I thank you specifically, Andrea, Kuyoshi, and all our colleagues at the Family Frontier Health Markets that were all part of this arrangement. I think with these few remarks, I turn it over to you, Farah. Thank you.
Thank you so much, Betha, for those very great remarks, both noting the good work that is being done in Malawi and also, what are still the thought processes, etc., that will take us forward. Now we have about, I would say, 15 to 20 minutes for discussions. I know there has been a very vibrant sort of discussion already ongoing in the chat. So yes, thank you for that. And they would like to share something. So if we can hear from someone like that, but then also I would really like to encourage some of us to come off mute and ask their questions, because I know on the chat there's already a lot of robust discussions going on. Anyone wants to come off mute and ask a question for any one of our speakers? Okay, I see silence, which means, I guess people are still digesting their information and all of that, which is great. But at any point, please raise your hand so we can, reach out or, give you that platform to ask your question. I think in terms of, some of the questions that, I have sort of been noting, for example, like I mentioned, right, one of the things that was just recently mentioned in one of the presentations was this whole question around, staff attrition at private health facilities. And I know that we've seen that in many other countries, and it would be nice to hear from the group if there are any thoughts on, what are some of the initiatives that can be done so that we are able to, manage that particular situation, because we may not have a lot of control over that situation. Private sector entities tend to be quite independent, etc. But any thoughts on the group on how we can, solve for that? Any takers? Can I ask Charles? Charles, and I believe it was in your presentation. Charles, what are you all thinking about as far as that challenge is concerned?
Okay, so
Yes, Charles. Charles, in case you are speaking, we can't hear you. I don't know whether it's a connectivity challenge.
that they should have a qualification on pharmacy. So what we are trying to do now is to ensure that maybe when we are doing the capacity building, the owners themselves, they should be among the priority people to focus on, so that as long as the entity is there, the owners will always be there. So maybe they could be the ones to actually build the capacity for the new other staff on the job now, to support them on the job. Because you train someone who is just employed, within a few months they're out there, it's becoming a challenge. But we are thinking maybe where the owners are actually actively involved in the business or in the service provision, there will be a better target to prioritize in the capacity building, so that they are able to share the experience or mentor the others when they have new staff coming in. But still it comes with the challenges where the owners themselves are just managers. They are not really active into the service provision. Yeah.
Definitely, Charles. And that's something that I know we've heard in other sessions from other countries as well, especially when dealing with these last mile outlets, whether it is pharmacies or drug shops. There is always this initiative to try and involve the owners. But then, yes, as you mentioned, the challenge remains that sometimes the owners may not be technical people. It could be a normal business person, and then it becomes a bit difficult to talk to them about specific health related challenges. Okay, thank you for that, Charles. Anyone once again to ask any questions? Yes, Andrea, go ahead.
Thank you, Farhan. I put so many questions in the chat. I found today's set of presentations just really interesting, and it was making me think about this topic of emergency contraception, for example, and the fact that virtually everyone who spoke has some level of participation or perception. And it seems to me that, and I forget, I think it was John's presentation that noted the really dramatic increase in volumes. And I just see a lot of opportunity there. So I think it would be an interesting kind of follow-on discussion. And then somewhat related, I have a question for anyone and everyone, and that is related to gender opportunities and gender challenges related to family planning, and definitely especially in the private sector and also in youth. And I also have heard that gender considerations are actually quite relevant in the realm of emergency contraception, because it could be either gender person who's sourcing the emergency contraception. So I'm just curious to hear generally about this topic of gender and how different partners and market actors are engaging on that topic. Thank you.
Thank you so much, Andrea. Is there anyone from the group who wants to respond to that? And I know one, for example, very interesting framing that's really coming up now, and I see more and more conversations around that is, you know, the role of men in family planning, and that somehow brings a gender element to it as well. But yes, go on, Martha.
Thank you so much, Farhan. Firstly, my comment will go to what my colleague from BLM, Charles, was talking about in terms of training the private sector, but now we see attrition. So you've invested in the trainings, but people are still going away of the private clinics. We were just wondering within PSI at some point, as in, I think we also, as NGOs, as government, we need to take an action whereby the trainings, we need to task the private clinics or private pharmacies that they should invest in trainings. As I indicated in my presentation, that you'll see that the quality of services is not, sometimes it's not, they are not up to the standards because the government is advancing with the guidelines, policies, protocols, but these guys are not making an effort to be trained. So perhaps the government should think of maybe putting CPD sessions online so that if a private clinic has either a nurse or a clinician who hasn't been trained in such a course, they are not supposed to practice, for example. So if they are mandated to do that as a CPD session in the private clinics, I think we can see a change or an investment from the private sector themselves. Or they will be looking for where the trainings are being conducted. But maybe sometimes they feel like, well, it's the government needing us to do this. They don't really pay attention. So it's something we can probably think about. Another thing on what Andrea was talking about on the how do we balance the youth or the gender aspect in the private sector. I would just to share what PSI has been doing in country, in Malawi. So we are working with the different segments of the population. Some youths are really coming from the rural areas. There are drugstores or private clinics in their catchment areas, but they can't afford to pay the amount that are being charged by the private clinics. Sometimes in the projects we are running, we give coupons to the youth to access the services at a very subsidized rate. So you do demand creation as PSI or as FHS, you give coupons to the youth, they go access the services at a very lower rate. So yeah, those are some of the initiatives we've done as PSI and also as our partners that we are implementing with. Thank you.
Thank you so much, Martha. Bertha?
Yes, thank you. So I just like to weigh in on the issue of gender. So we have a Momentum sister project, which is a sister to the Momentum Tiyeni. This is Momentum Tikweze Umoyo. So what they are doing, actually, if it was something that is to be capitalized, that would be something that is really trying to explore the gender component on the private sector. So what they're doing is that they are working with the Kabaza the Kabaza guys. So they do train these Kabaza guys and give them the leaflets which has information on the family planning, so that these should be also be able to share with others, the fellow Kabazas or other colleagues in the space, raising awareness on family planning. The aim is to raise awareness and also increase men's participation in FP issues, but also increase men's support for women to access FP services. So that's something that I wanted to share. It's a kind of a male championship, a kind of a male engagement, but it's really engaging those men that are doing the Kapaza kind of small scale business to just to earn a living for them to feed themselves. Not like they're doing a family planning business, but they are being utilized in this way. Thank you.
Thank you, Betha. Betha, just for clarification, does Kabaza mean informal workers? Is that a good way to translate that? Because like me, I'm sure there are people in the group wondering what that word means.
Yes, so my fellow colleagues here in Malawi, possibly Martha and others can come in, or Olive, but these are men that they run these taxis like motorbikes or motorcycles to transport others, people who don't want to like to walk or by foot, right? That's kind of a business. So these are the men that are being engaged on this. Others are those that are working also in the barber shops where men can go and shave their hair. So those are the Gabaza. I hope that's clear, Martha, Olive. Is this the right meaning for Gabaza? If you want to add in to what I've said.
Yes, Peter, you are right. These are just bicycle taxis. So they are mainly managed by men, and many of the passengers are women. So I think it's a good example of gender mainstreaming in the private sector.
Okay, thank you for that. And just for knowledge, in Tanzania they are called boda bodas. So I guess there's a name for them in probably every country. Welcome, Cindy.
Thank you, Farhan. I just wanted to follow up a bit on Andrea's section and so the very in terms of what's collected by project back in 2022, we only report that we're can you guys hear me okay?
Yes, Cindy, you are breaking. I thought it was my internet, but it looks like it's everyone. So if you can just repeat, please. Yes, it was breaking quite a bit.
Okay, sorry. Can you hear me better now?
Yes, much better.
Okay, sorry. So I was just saying, you know, responding to Andrea and all of the interesting comments around emergency contraception in the chat. I just wanted to add that, you know, we actually may be underestimating as well the role of the commercial sector and the significant growth that has taken place for that product. When we collected that data back in 2022, I think there were only a handful of importers, well, the major importers, but we probably missed some data. So that's one point. I think it would be really interesting for the PROPEL Health team to think about also updating some of that, or others updating some of that total market data. And just a final thought, I mean, I think it represents a very interesting potential partnership. We've talked about youth, we've talked about addressing some of the demand challenges. And I think it represents a really interesting potential partnership with the commercial sector around ECs, you know, between the social and behavior change players in the market, the commercial sector, obviously bringing in the product, and maybe even some of the social marketing organizations. So those were my thoughts around EC. It's something that I'm also very interested in. And obviously it's, you know, we've seen that trend in many other countries in East Africa, not only Malawi. Over. Thank you, Farhan.
Thank you so much, Cindy. And I mean, I think one of our major sort of goals and objectives as this community of practice is exactly that, right? That we hope that beyond this, you know, discussion and all of that, perhaps all the presenters who are here can sort of come together, because we do understand that there are, for example, structures within the different countries, like so family planning, technical working groups, etc. But many a times, you know, private sector is not that much of a strong discussion in those spaces. So if, you know, a lot of these partners, presenters today can, you know, come together and discuss on some of these things, brainstorm more at the country level, I think that would be a great success for this session and for the community of practice in general. We do have, I would say, around 2 to 3 minutes more. If there are any hands or any feedback, comments, thoughts. Cindy, your hand is still up. Do you want to?
Now, thank you, Farhan.
Okay. No worries. Anyone else with any comments, thoughts? Andrea, happy with some of the things that you've heard. Of course, I know there are a lot of conversations that we can have, and I know, as we think about the community of practice sessions next year, and think about doing more thematic sessions, I know we've discussed doing some kind of sessions specifically on gender as well. So that's also something for us to keep in mind. And if anyone wants to join us in organizing a session like that and talking about gender dynamics within this space, more than happy to collaborate and work together.
Yeah, thank you, Farhan. I'm just going to jump in, coming off mute here to say, absolutely. I mean, I think we see a lot of variety from one healthy market session to the next. And just this one today, I think just had a lot of really extra positive energy and connection, and a huge shout out, honestly, to Cindy Cizik for kind of behind the scenes support with a lot of what occurred, and for really regular participants like Anne and Pitzer, and also to say we really are trying from a USAID perspective. Ultimately, we very much want to facilitate a true community of sorts. And so I think that's what FHM Engage is definitely working on. So if you have ideas, if you want to help co-plan and co-lead with Farhan and Dunya from FHM Engage, or create some spin-off sessions, by all means, because that is really the intent. Thank you.
And yeah, Andrea, I think since there are no thoughts, do you want to just add on some closing remarks to that? I think we can close the session for today, since I don't see any pending comments or any hands up. Okay, maybe we should consider those the closing remarks then. Thank you, Andrea, but please feel free to jump on if there's anything more to say. But yeah, so thank you so much, everyone today, Propel Health, for being amazing partners for us in organizing this session, and to all our speakers. And I think there was a lot of robust discussion today, which is great, which is, as mentioned, exactly what we want to see as a community of practice. So our final session for 2024 will take place sometime in December, to make space for the Thanksgiving holidays and some of the other sort of, end of year schedules, but also be one before the December holiday season. And that is going to be more of a thematic session that will focus on pharmacy and drug shops. And, because I have some time, as I have shared before, for next year, we are looking at, as a community of practice, to do sort of a mix of sessions where we will have some country-based sessions, and we will have some sessions that will be more thematic. And we are already seeing, some of those themes that have been coming up over the years or over the months that we've done the sessions. But if anyone has any ideas, etc., please do reach out. We are currently planning for our sessions in 2025. But yeah, thank you so much, everyone. Today, I can actually give people a minute or two of their time back. These are our contacts. Please feel free to reach out in case there are any thoughts, questions, etc. We will be sharing this recording along with a summary of the session with everyone present and everyone on the listserv. Thank you so much, everyone. See you at the next session.
Thank you.
Thank you. Bye.
Thank you. See you later then. Bye.
Bye. Thank you.